computer. Okay, so let's start with today's topic. So today's topic is basically about mania and psychotic disorders. So the title which I have written here is Bipolar Affective Disorder. What we need to understand is that bipolar affective disorder includes mania. It is visited. Okay, I'm so sorry. Okay, wait. The topic today is mania and other psychotic disorders, right? So we have to understand the difference here that mania is basically a symptom of bipolar affective disorder. What it is, we will discuss from here on. And also, what are psychotic disorders? So first, we will talk about psychosis. What is psychosis? So psychosis is a condition where a person's perceptions and thoughts are distorted because of hallucinations and delusions. We will also be discussing what hallucinations and delusions are. Here is a slide. If you look at this slide, there are two circles. The blue part is mood disorders and the red part is psychotic disorders. And if you look in between the green oval, it includes bipolar disorder, depression, and mania. Bipolar disorder basically is a mood disorder, which includes episodes of mania and depression. And mania basically is a state which can have psychotic symptoms or psychosis, which includes hallucinations and delusions. So here we have an overlap between the two. Just look at the image again and you will understand that mania basically is a mixture of mood symptoms as well as psychotic symptoms. But it is a feature of bipolar disorder, which is a mood disorder. So there's a minor overlap over here. Yes, we have a question. Can depression? Yes, it can have psychotic states. Definitely it can. So there's no clear-cut, you can't say depression only goes through. That's why the oval is overlapping. Depression, when it gets severe, it has psychotic features, which includes delusions, hallucinations, and lack of insight. Okay, so moving forward, I'm glad that people understood this. Just have a look at this. It may seem complicated, but it's not very complicated. Basically, what they're trying to explain here is that mood disorders, they lie on a continuum, right? On one end is mania, on the other end is depression. And when mania is very severe, if you look towards the extreme left, it presents with psychosis. And also when depression is very severe on the right-hand side, it can present with psychosis, right? And in between, there is mania, hypomania, elation, normal mood, dysthymia, everything is included over here. And then you can see that the broad arrow, the bottom one, the extremely bottom one, it says bipolar affective disorder. So just concentrate on that because the other ones will become too complicated since we have to talk about both mania and psychosis. Okay, what basically is bipolar affective disorder? So basically it is a mood disorder. It was previously called manic depressive illness or manic depression. And according to the WHO, it is the 6th leading cause of disability in the world. What is mania? Mania is an extreme elevated mood state. Someone who is in a state of mania, they describe their experiences as more vivid and pleasant, and there is an increase in energy and alertness. Also included with mania, what happens is mania, people who have mania have increased energy, they have a decreased need for sleep, elation, and also self-important ideation. Now, when self-important ideation comes in, it can turn into a delusion, which we call delusion of grandiosity. Right? And in delusions of grandiosity, the person believes that they are someone important, or they can perform any task in the world. For example, they are the prime minister, or they are the messenger of God, or God talks to them, in which case they are also having hallucinations, and so on. And obviously, mania is a symptom of bipolar. So there are manic episodes and depressive episodes. Okay, so if you look here, mania, it is a high, right? Overexcitement, restlessness, high sexual drive. They're impulsive, make unrealistic plans. Why do they do that? Because they have delusions of grandiosity. They believe they can do anything. So they make unrealistic plans at that point in time. And it has, there's a greater chance of drug and alcohol abuse during that. Depression is the complete opposite, and you will probably be covering that in mood disorders. Okay, so where we have mania, we have hypomania, which is a less severe form of mania. Now, here just I need to explain to you that where mania can have psychotic symptoms, since hypomania is a less severe form of mania, it does not have psychotic symptoms. That's how the two are differentiated. So hypomania is a less severe form of mania. There is a feeling of euphoria. People are energetic and productive. And for the rest of the people around them, they think that that person is unusually happy. There is no interruption in their daily life. So they're carrying on their daily activities. They do not lose touch with reality. A major difference between mania and hypomania. Always remember, where psychosis comes in, they lose touch with reality. And where there's no psychosis, they are in touch with reality. So here, if you look at it, mania versus hypomania, mania may cause severe impairment in social or occupational functioning because mania includes psychosis and hypomania does not include psychosis. Here is another spectrum showing how mania can be severe, it can be hypomania. There could be a normal and balanced mood in between. Another slide showing the types of bipolar syndromes, extreme mania, which is bipolar. In bipolar type 2, there is hypomania, not mania, hypomania and depression. There can be mixed states with both mania and depression at the same time. And yes, during the mixed state, the patient might have psychotic symptoms. Rapid cycling means there are 4 or more episodes per year. Okay, so this slide is a little unclear, but let's talk about psychotic disorders because this is very important to understand. So when a person has a psychotic disorder, there is a significant loss of contact with reality. And there are 3 types of symptoms. They can have positive symptoms, they can have negative symptoms. Are those symptoms which an ordinary person does not have, a normal person does not have. Because I just got a message that can you see the screen right now? It's visible, okay. All right. So positive symptoms are just those which a normal person does not have, which include delusions and hallucinations. So you are adding positive. Remember, positive means you are adding those symptoms to a person. Those are positive symptoms, delusions and hallucinations. A normal person does not have delusions and hallucinations. In negative symptoms, such people, they have avolition. Avolition basically means a lack of initiative to do anything. They're unable to get up from bed. They are unable to even think about initiating any task. It is called avolition. I'm going to spell it out since I feel that you probably cannot see it. So it's AVOLITION. Anhedonia, which is a lack of interest and enjoyment in daily activities. Alogia, which is a decreased speech, or you can say that the patient becomes silent. Blunted affect. So I hope that previously you have learned the difference between mood and affect. So when we say bipolar affective disorder, affect means what you are observing in the person. Mood is what the patient states. So for example, the patient can say they are very happy, they are feeling might not seem very happy. So what we observe is the affect. So blunted affect means that the person will have no expressions. When you look at them, they will neither be smiling nor crying. They will not respond appropriately to any stimulus during that time. So, like if you make a joke in front of them, they might smile. So, their affect remains blunt, right? And asociality. So basically, they become silent, aloof, they have social withdrawal, lack of initiative to do anything. So those are negative symptoms. So a normal person does have all this. So you're taking out these symptoms from them. Disorganized symptoms basically is something to understand that a person can have behavior which is unusual, and they can have speech which is very unusual. You might not be able to understand what they're saying. It may be very jumbled. And they may jump from one topic to the other. With disorganized behavior, they might be sitting and you might observe them to be talking to someone or any other type. They might have some stereotypic movements. So positive symptoms with delusions, hallucinations, negative symptoms where there is a lack of initiative, decreased speech, lack of interest and enjoyment, blunted affect, asociality, and then disorganized type. So here is the difference. What are delusions, hallucinations, and illusions? So basically, conceptual abnormalities. And illusions, we have all experienced illusions at some time in our life. So basically, illusion is an abnormal perception in the presence of a stimulus. So for example, you are sleeping, you're trying to sleep, you're about to fall asleep, and the curtain, you see the curtain in, it's moving with the wind, and you think it's a ghost. Or you're walking in the dark and there's a stick lying in front of you, and your perception says like it's a snake. So we have the stimulus there. The curtain was the stimulus, which the person is mistaking as a ghost, and the stick is the stimulus, which is being misinterpreted as a snake. So illusion is basically misperception of real external stimulus. Remember, there is a stimulus. Hallucinations, on the other hand, there's no external stimulus. So it's a false sensory perception without any external stimuli, right? And when you ask the patient about them, so hallucinations can be in the form of voices, they can be visual hallucinations, they can be gustatory hallucinations relating to the taste of the five senses, tactile hallucinations relating to the touch, and olfactory relating to smell. So the most common type of hallucinations in psychiatry are auditory hallucinations, which are part of psychosis. They're the most common type. And then visual hallucinations. The other form, and tactile as well. And the other forms, olfactory, gustatory, even visual hallucinations are more common in neurological disorders or substance use. So hallucinations and illusions, they are misperceptions. Right? Delusion, on the other hand, it's a form of thought disorder. There are false, firm beliefs which are not real. They cannot be corrected with argumentation or by logic. And they are not consistent with the culture and education of the patient. Why do we say culture and education? So you know how in our culture, it is very common for people to think that hum pe jadoo ho gaya hai. And then there are people who have delusions, who are convinced absolutely that some form of black magic is being performed on them. But when you talk to the family, they don't believe it. They say, no, there's nothing like that. And with the delusion, the person will have some form of story relating to it as well. So, for example, there's a male patient. He'll say, my wife is trying to poison me, or she's doing black magic on me. But the rest of the family denies it as well, collateral account. So, consistent with our culture, a lot of people come and say, कि मुझ पे जादू हो रहा है, कोई तावीज कर रहा है या जिन आ गया है. Right? So that is consistent with culture. And when you speak to the family, they're also believing it. But at some point, when you try to argue with them, or you try to correct that belief with logic, that belief will shake. Whereas a delusion is fixed. It cannot be shaken. It cannot be shaken with any logic, no matter what sort of proof you give to them. So that's what delusions are. Delusions can be paranoid type. Like I just told you, someone is trying to kill me, someone is trying to poison me, and so on, harm me in some way. Then there, like we spoke about delusions in mania, delusions of grandiosity, when the person believes there's someone important or they have some higher form of power, they can do anything in the world. There can be delusions of infidelity, that their spouse or their partner is cheating on them. So these are some sort of delusions. Okay, so psychotic. When we were talking about bipolar affective disorder, mania is one phase of bipolar affective disorder, which has psychotic features. However, bipolar affective disorder is classified in mood disorders, whereas psychotic disorders are a little different. Here is a list And I'll try to briefly explain to you what each of these psychotic disorders are. So one type is schizotypal personality disorder. This is basically a disorder of the personality, and the person begins to show, or the signs start and symptoms start to become more obvious after adolescence. However, during childhood, the person might have some sort of different personality. So in a schizotypal personality disorder, the person's behavior is a little odd. They will dress differently, maybe wear very colorful clothes. Their thinking is different, which we call magical thinking. They have odd behaviors, speech patterns, thoughts, and perceptions. So basically, sometimes there are people we come across, maybe in life, maybe we're passing by somewhere, and they seem a little strange or different or eccentric. Such people dress, speak, or act in an odd or unusual way. And they can be suspicious and paranoid. So basically, it's a disorder of the personality. It's persistent. It starts from more from adolescence. There may be features during childhood as well, and it persists throughout life. So such people hardly ever present to the clinic because it's a disorder of the personality, except if they have a psychotic episode. Schizophrenia is the main psychotic disorder which we usually get in our practice. Schizophrenia is something, it's a disorder, psychotic disorder. People who have schizophrenia should have delusions, hallucinations, lack of insight as symptoms to be diagnosed. They can also just have delusions or just have hallucinations as well. Lack of insight is something which should be present. They do not think they're ill. And people with schizophrenia, their lives are, because it's a chronic, persistent, and severely debilitating disease. So their day-to-day life is very affected. Even with schizotypal personality disorder, you can say that their daily life is affected. Schizoaffective disorder. Now, this is where it's a little interesting, and I know it can get very confusing. If you just look at the word itself, schizo and then affective. When we talk about schizophrenia, it's a psychotic disorder. When we talk about affective, that's a mood symptom. So what is schizoaffective disorder? It is an uninterrupted period of major mood episode, either manic or depressive, and is concurrent with positive symptoms of schizophrenia. Remember, we spoke about positive symptoms, hallucinations, and delusions. So basically, it's a mix of the both. There should be major mood episodes, either manic or depressive, along with positive symptoms for at least 2 weeks. It can be bipolar type and depressive type. Schizophreniform disorder is basically something, it's a disorder where a patient who presents with schizophrenia symptoms, they've had the symptoms for at least 1 month, but less than 6 months. So at 1 month, we say they have acute psychotic disorder. Less than 6 months, greater than 1 month, less than 6 months is schizophreniform disorder. And then when 6 months have passed and the psychotic symptoms have not, they persist, that's where we say that it's schizophrenia. Delusional disorder. So people who present with delusional disorder, what happens with them is that they have delusions which are well systemized and they are non-bizarre, or they might even be bizarre. and it is accompanied by mood or affect appropriate to the delusion. Now, what happens here is that, let's say, if you look at this, bizarre content includes delusions that are not understandable or they're not from ordinary life. So they're talking about a person who says that his or her organs have been replaced with someone else's organs. And when you speak to them, they will have a very systemized story about how it happened. So for example, the person might say, I went to sleep and then I was taken by aliens, or, I was kidnapped and my organs were taken out. So they will have a whole story revolving around it. They will be systemized. And then their affect or their mood will be according to the delusion which they have. So here they might be distressed or depressed. And delusional, yes, it can be. It can be. That's what I'm going to talk about. So remember that delusions in schizophrenia, the person with schizophrenia can have one delusion, one type of delusion. They might have more than one type of delusion. And usually, let's say that they have paranoid delusion. So they will just say, हाँ, मेरे घर वाले मेरे दुश्मन हैं. So किस तरह से दुश्मन हैं? मुझ पे जादू कर रहे हैं. So basically, they will have an explanation for it, but there will be they're not systematized. Whereas here, they are systemized in such a way that they will have the entire story from where it started, how it happened. And here, the interesting bit is that people who are diagnosed with delusional disorder, their personality is well preserved, or their day-to-day functioning is not normal. However, people with schizophrenia, part of the diagnostic criteria for schizophrenia includes that their day-to-day life is affected. So a person with delusional disorder otherwise carries on relatively well with real life. Their personality is fine, but they will have these delusions which are systemized. They can be bizarre, like we spoke about, the organs being removed, and they can be non-bizarre. So for example, very common which we get is my wife or my husband is cheating on me. And then, they have this whole delusion revolving around it. They will have the whole story about how it started, how the husband or the wife who's cheating, how they speak to the other person. So that's more like non-bizarre. It can happen in real life, and so collateral accounts are needed about whether it's true or not. So that's the main difference. Schizophrenia, the person's day-to-day life is affected. They have lack of insight. Yes. How to differentiate between schizoaffective and major depressive disorder with psychotic features? Okay. So let's go back to schizoaffective. Here, you have to remember that where there is schizoaffective disorder, they said there can be a major mood episode, either of mania or depression, along with positive symptoms of schizophrenia. So since, the diagnostic criteria for schizophrenia is a little complicated, schizophrenia symptoms, so when a person has major depressive disorder with psychotic features, they will have a prolonged period of depression. And then the psychotic symptoms which they have are mood congruent. Okay, you have to understand that. So what mood congruent psychotic symptoms are is that their delusions, their hallucinations, will be in accordance with their mood. So, for example, since the person is depressed, they're unhappy, they're abnormally sad, their delusions will revolve around things like, I have some terminal illness. They're convinced of it, they have a delusion. Or, I have lost everything in life, I have become very poor, I don't have anything. And even the hallucinations which they experience, they are usually very negative. They're derogatory. So voices telling them that they're not worth anything, or they should go and kill themselves since their life is useless. Whereas over here, they say positive symptoms of schizophrenia. So in schizophrenia, the delusions or hallucinations are of a variety of type. Paranoid, then there are commanding hallucinations, there are third-person hallucinations. So, where they say criterion A, I have not shared it with you because it's already, the topic is very confusing as it is. So remember that to diagnose positive symptoms of schizophrenia, there is a particular criteria. There is a particular type of psychotic features which they should have. Whereas in a major depressive disorder with psychotic features, the patient will have mood symptoms, severe depression, along with hallucinations or delusions which are mood congruent. They're in accordance with their mood. They're depressive. Okay. Then we also have substance or medication. So let's see. Brief psychotic disorder, remember that it is the presence of psychotic symptoms for less than 1 month. That's when we diagnose it as brief psychotic disorder. Do not we'll skip catatonia. We'll come to substance or medication-induced psychotic disorders, psychotic disorders due to another medical conditions, and then there are others or unspecified. So substance or medication-induced psychotic disorders, some substance is capable of producing hallucinations and delusions. Right? So substance is any recreational drug such as cannabis, meth, crystal meth, methamphetamine, alcohol, which is inducing some sort of psychotic disorders. Some medications which include corticosteroids, antituberculous drugs, they are also capable of inducing psychotic symptoms. So, they can occur during intoxication or during withdrawal. So a lot of times we are called by the medical units where the person is taking steroids and they start developing psychotic features, either delusions or hallucinations. So they are treated accordingly. And also, obviously, as a psychiatric unit, we have a lot of patients who come with substance-induced psychotic disorders, which includes cannabis, alcohol, methamphetamine, which are most common. LSD is not so common here, but that can also be included. And then there are psychotic disorders due to another medical condition. So some medical conditions more often, something which involves the HPA axis, the hypothalamic pituitary axis, such as hypothyroidism or hyperthyroidism. So there could be an underlying medical condition. Or there are certain types of other conditions, such as, people with SLE, systemic lupus erythematosus, they might have psychosis. So there will be an underlying medical condition. And then when that medical condition is treated, the psychosis also starts to resolve. Here, you just need to understand that it happens. The medical condition brings about the neurochemical changes. don't go into too much detail because as it is, it's very complicated. I will just, briefly so that you retain what psychotic disorders are and what mania is, go through the etiology and the treatment for them. So basically, how do these disorders, either mood disorders or psychotic disorders, both of them. In psychiatry, we talk about biopsychosocial factors, right? So in biological factors, we have neurochemical changes, hormonal changes. In psychological factors, there might be childhood experiences, current stressors. Social factors may be poverty, joblessness, right? So when a person has all three and there is, they might have dormant disorders. And it's not just for mood disorders, even for psychotic disorders, this is how the etiology goes. So they will have some stressor and their symptoms set in. The biopsychosocial stressors were already, causing them to be vulnerable, as we see in the orange oval, and they were protective factors. Mood disorder, it could be psychotic disorder. Always remember biopsychosocial factors are involved in their etiology. Problems with the internet connection. There we go. Briefly, let's talk about biological factors. They can be genetic, they can be neurochemical. Environmental factors, which may be life events, drug use, stress, substance use, which may induce mania-like episodes. Then there are medications, corticosteroids, thyroxine, chloroquine, excessive caffeine. Then what treatments can we have for the psychosis and for mania? So here also we use the biopsychosocial model. Biological treatment includes medications. For mania, there will be so remember that works, counseling or psychological therapies should be started. The person has insight into their illness. So usually when a person has psychotic symptoms, biopsychosocial model, and then these we were talking about psychological therapies, right? For mood disorders, we have mood stabilizers. For psychotic disorders, we have antipsychotics. Here are some famous people who have publicly stated they have bipolar disorder. There's some interesting facts. And, some of them have in this list actually did not just have bipolar disorder. Some of them had schizophrenia as well. If you look here, Vincent van Gogh, the artist, he had schizophrenia. You can see that most of them who have bipolar, they are like very creatives. They are movie directors, writers, musicians, artists. Right? So here are two spectrums of bipolar disorder and So with that, we will, start end our class. We can have a question and answer session. Anyone who has questions regarding mania, regarding psychotic disorders, anyone who has questions? I could also get you unmuted. Okay. I have can delusional disorder progress to become schizophrenia? Yes, it could. There's no hard and fast rule here, but yes, because it involves the same neurotransmitters. Usually it remains a delusional disorder, but in some cases it might progress to schizophrenia. Most definitely it could happen. There's no rule which says it cannot happen. So it might start with a delusional disorder. And since, the same neurotransmitters are present and maybe the person also has some sort of vulnerability. Let's say the person has genetics which make him more prone to schizophrenia. It can progress to schizophrenia. Okay, anyone else who has any questions? I know it was a bit confusing. I tried my best. Just remember, mania is a mood disorder and mania can have psychotic symptoms. In fact, it does have delusions of grandiosity. Also, it can have hallucinations. And then psychotic disorders. When you say they can't be cured, no, that's not true. So we do have antipsychotics. And for specifically for schizophrenia, because we diagnose a patient with schizophrenia after they have had treatment, after they have had symptoms which have not even resolved with treatment for 6 months. We give them that much of a time period to go back to normal. So remember that 33% of those who have schizophrenia, they recover completely after a single episode. You know how we spoke about brief psychotic disorders, symptoms which last less than 1 month? They resolve, right? It can be cured. Sometimes with medication, some people even resolve without medication. And 33% are those who remain stable with medication, stable enough to carry on their day-to-day activities. They might not have 100% functioning. Yes. I'll also answer that. And then 33% are those who never get better. They don't respond to treatment as well. They have a chronic deteriorating course. If left untreated, do these worsen? Yes. So the longer the duration of untreated illness, the worse the symptoms become. We have, just understand that in psychiatry, since it is, there is no one single cause for any of the disorders. There are multiple causes, like we spoke about biological, psychological, social factors. So we say that most of the disorders are multifactorial in origin. So some people, have genetics and they will have a brief psychotic state or brief psychotic disorder and they will become okay. They will, go back to baseline. And then, some might progress to schizophrenia. And for those who progress on to have a diagnosis of schizophrenia after 6 months, they are those who were left untreated most often. So the longer the duration which is left untreated, the symptoms are worse. Treatment started within 1 month or at the earliest responds very well to antipsychotics. All right, any other questions? So with that, we'll end the class, and I hope I could get the message across to all of you. And inshallah, till next time, all of you take care of yourself and Hafiz.